Welcome to MAP, the bi-weekly market access podcast hosted by me, Dr. Stefan Walzer. I am the innovator of Market Access 4.0 and a health economist by training and working in the fields of market access, reimbursement, pricing, and health economics since 2004. Discover Market Access 4.0 and unveil the future with our innovative solutions. Max Insights, our fast and easy AI-based reimbursement planning platform. Dobo, our new revolutionizing way of creating reimbursement dossiers across the globe with the first and only dossier writing AI bot. Cubo, our new AI-based objection handling platform. And Waffle, train with Waffle's virtual reality genius in an immersive environment and with an AI-based counterpart. We are Market Access 4.0. So check out our website, marketaccess4-0.com. And now let's dive into the current discussions, processes, and trends in market access across the globe. Welcome to another episode of MAP, the Market Access podcast. Today, we're as well moving again outside of Europe. So we're moving towards the direction of Australia. And for that, and for the detailed discussion around the system, but also a bit beyond, I'm happy to have a great guest here with Zanfania Ademi. And whoever does not know you yet, please quickly introduce yourself.
Thank you, Stefan, for the invitation. My name is Zanfina Ademi. I'm a health economist. So I'm a professor here at Monash, and I lead a group called Health Economics and Outcome Research, which is nested within Faculty of Pharmacy and Pharmaceutical Sciences at Monash University. I lead a very multidisciplinary team, pharmacists, epidemiologists, health economists, and we look at different issues on health economics, look at the economic evaluation alongside trials, clinical trials, real-world evidence. We look at decision economic modeling. Recently, in the last decade, we've been working quite a lot on productivity, health productivity and impact on diseases, but also we do a lot of work in distributional health and equity.
Perfect. So it is a wide range, and I'm happy that we can maybe at least touch base on some of those areas in the next couple of minutes. But maybe before digging into some of the maybe more detailed parts like health, productivity, equity, but also around a couple of others you have just mentioned, for the listeners, could you just summarize firstly, if we would start from a reimbursement market access perspective, how the system in Australia works?
Yes, gladly. So Australian healthcare system in the regulatory path, in terms of when you look at safety and efficacy, goes through therapeutics, goods and administration. Whereas when we look at from a reimbursement perspective, there are two most important bodies which federal government supports the funding for those. It is called Pharmaceutical Benefit Advisory Committee, which informs pharmaceutical benefit scheme for reimbursement of new drugs. And it does this through two very important subcommittees. One is called Economic Subcommittee, and the other one is Drug Utilization Subcommittee. So one looks at clinical and economic evidence. The other one obviously look at economic and clinical, but look at more budget impacts and utilization of the drugs. Then there is the Medical Service Advisory Committee, which advises on Medicare benefits schedule. And this covers a wide range of health services to be reimbursed. So both of these are separate committees, but they use the same principles. like any HTA. So they would look at clinical value, they would look at cost effectiveness value, a budget impact analysis, and in some instances, they will look at additional value that technologies might add beyond healthcare. But how that additional value is included for decision making, it's not that clear in the guidelines. Both of MZAC and PBAC value consumers and clinicians' inputs as well. And consumers have a say on it. But again, in the guidelines, it's not clear how that information that will impact the decision making or final decision making for drugs to be reimbursed or for a range of other health services.
Got you. So I think this is giving a quite nice kind of overview. I mean, it looks like generally it is probably handled like in a couple of other countries, maybe rather a bit closer to, I guess, like in the UK and Canada. Not so much, let's say, like we see it, for example, in Germany and some of the others, but it's probably kind of good mix of HTA driven versus, I think you said it, I want to call it maybe a bit of a black box part where, let's say, decision making is not always that clear in terms of which areas are, let's say, covered in which ways, right?
And also equity is something that is also considered. Mm-hmm. And I assume that in a lot of HTAs, equity is considered when we look at rare conditions. But the way how it's considered in the Australian HTA, it's more qualitatively than quantitatively.
Okay, yeah, that's a good one, because I mean, what I had already in mind, you mentioned in your introductory words that you're also, or you and your team have been working also on equity. So, I mean, you can as well, of course, include it qualitatively or quantitatively, as you have as well just indirectly said, right? So are there any, let's say, directions or maybe even discussions in Australia where maybe that qualitative bit for equity could maybe as well be included rather quantitatively? I mean, we probably know that there's also kind of those kind of, let's say, distributive cost effectiveness analysis, which basically would fit from a quantitative perspective. Are there any kind of direction that Australia might adopt, or is maybe even trying that? Or is it still, let's say, rather, let's say, a bit of an academic exercise? And let's say from a decision-making perspective, they still, let's say, focus on qualitative aspects?
At the moment is very qualitatively driven. Mm-hmm. There are a lot of academic groups that are working towards a distributional cost effectiveness analysis or group-based equity analysis. At the moment, there is a lot of discussion. Australia has gone through a HTA review. Mm-hmm. And hopefully, based on this HTA review, we will understand whether some of those methods will be appropriate to be included into a decision-making. It is something that my team works quite a lot. We look at first distributional health in terms of life expectancy at birth and quality-adjusted life years at birth. And then we look at the difference by socioeconomic status. Mm-hmm. So socioeconomic disadvantage, and we look at what is your life expectancy of someone being in a high socioeconomic group in comparison to low. And then we look at by education as well. And this is something that it's most commonly used in Europe and in Canadian HTA. And this information then can be embedded into a distributional cost effectiveness analysis. As we know, cost effectiveness analysis give the averages, whereas distributional cost effectiveness analysis can give which groups might benefit the more or where the intervention can be implemented in public, private, or specific groups. So even when the intervention might be cost effective, sometimes it might not improve equity. It actually might make equity worse. So we have done recently one analysis where we have looked at the gestational diabetes and interventions that are done during pregnancies in women. Our overall cost effectiveness long-term modeling has shown that it's cost effective, but then we know that government is not willing to pay at one point in time for all pregnant women. So that's why we wanted to see where it will benefit most. And what we've shown is that if it's implemented in a public system, in public hospital, or potentially driven more towards a higher BMI group, it will improve equity and efficiency rather than implemented in private or to all age group categories.
Mm-hmm. That's quite interesting. I think that was also a bit of my question. I mean, I just had as well a discussion quite recently with somebody from New Zealand, where I think equity is, of course, as well a big driver, let's say. But I think to remember it was also rather qualitatively instead of quantitatively, but it is rather, let's say, anchored in the whole kind of decision making. It's always in their mindset, right? So I think here it would make sense. I mean, as you have just said, to at least have an idea how those kind of equity measures could maybe as well be included quantitatively.
Yeah. So there are some guidelines that specifically says how you do it, but there are challenges. Mm-hmm. First of all, it's new method. It's very complex. Mm-hmm. It's going to take a very long time to train people to understand, appraising team, evaluating team, and the decision makers. And as pointed out, some HTAs have a specific inclusion of distributional cost effectiveness analysis in Asia. India is one of the countries who has specifically included distributional cost effectiveness analysis. I know that NICE and Norway look at specifically sometimes for some diseases and might use some form of quantitative methods to look at the impact on cost effectiveness or impact of interventions, how it changes the outcomes.
Yeah, I think the whole discussion brings me basically to another question, because you also mentioned, let's say, that you're also, let's say, working or have been working on quite complex disease models, which is also a bit linked, of course, because equity is maybe more towards the end of everything and the interpretation and the decision making, of course, political impact. But I think a lot of times this has, of course, let's say, the starting point rather with those complex disease models. I think you mentioned beforehand, I think different cardiovascular diseases, for example, prevention. The issue from my perspective is always when we have done some modeling, especially when speaking then with politicians, policymakers, the long-term effect, right? I mean, clinical studies are rather short-term, even if they're running maybe for a couple of years. If you have such kind of diseases, you would need to extrapolate in one or the other kind of way. Is this as well something which the Australian system is prepared for, or maybe even already including, or is that rather still as well a bit of a preparatory kind of work? Or as you have just said, I think the HTA generally is under review, and maybe this might come up again in the near future.
I feel that this part is in infancy. There are a lot of primary prevention or primordial health economic models that are done. But I feel that almost all HTAs operate in a reactive mode rather than proactive mode. Mm-hmm. I don't think at the moment the way how we reimburse drugs or with medical benefit schedule, the focus is not as much in prevention. I feel like there is almost a need for a separate HTA to look at primordial and primary prevention, because how we define prevention, there are different methods and ways how people think. Primordial is when nothing has happened in terms of you don't have high risk of risk factors, for example, especially those that are modifiable. And then primary would mean that you would treat a high risk factor, right? Mm-hmm. But I feel that we would definitely need a different HTA process to look at the prevention strategies, whether being new treatments, or whether being a screening or testing strategy to identify people at potentially at high risk of disease. And Stefan, as you know, and you pointed out, clinical trials are very short in time horizon. We will never be able to run a clinical trial that is going to look at primary or primordial prevention. So our team has looked at a way how we can do prevention by using real-world evidence. Mendelian randomization has been something that has been in public for so many years in terms of epidemiology, but in health economics is still in its infancy. And we've been working quite a lot in this space, specifically with regards to cardiovascular disease. And the way why we are choosing the Mendelian randomization is because it's the only method that could potentially provide a causal evidence. So in the same way that randomized clinical trials would. But we are not saying they are the same, but this is the best way how you can move forward. And we have done, we have used the Mendelian randomization evidence to look at the prevention of cardiovascular disease, specifically with modifiable risk factors such as cholesterol level, systolic blood pressure, smoking, physical activity, and diabetes and lipoprotein A. And we build a life course model. The difference of this model to other existing cardiovascular models is that it looks at cumulative impact of risk factors. So it doesn't look at one point in time, but it looks at how new prevention strategies can change the outcome. And we have demonstrated this by implementing in several instances. For example, we've used Mendelian randomization with regards to familiar hypercholesterolemia. It's a disease that starts in birth, and children who have a very high cholesterol can start treatment with statins at very early age. So we looked at here cholesterol years to model the impact on coronary heart disease and overall mortality. We have shown that with this similar model, we've shown that if we would look at a new intervention from a short-term horizon like 5 years and 10 years versus lifetime, it provides a completely different results. And recently, we just implemented the same methods for testing for lipoprotein A. Lipoprotein A is something that it's prevalent in our population, around 20%. So 20% of population have a high lipoprotein A, and we wanted to understand impact of lipoprotein A in concert with other traditional risk factors, how it's going to change the outcomes if it's implemented. And what we've shown is that it's not only cost effective, but it's cost saving in high income countries. So this is one way how you can demonstrate implementing complex models which take disease biology into consideration, cumulative impact or cholesterol years, blood pressure years into account, and give advice on prevention strategies over long term. It's always difficult when we have to discount by 3% or 5% those long-term 70 years models. And that's why it's very important to conduct a number or series of sensitivity analysis where decision makers can look at different ways how you can discount and impact the long-term outcomes.
Yeah, exactly. I think that makes a lot of sense. I could understand, of course, let's say, and probably most of us could generally, let's say, agree that, let's say, such kind of prevention measures should somehow lead into, let's say, cost savings. I think with all of the different kind of analysis and steps, I think makes even more sense. How do you see the potential implementation there? Maybe not so much from a modeling perspective, but maybe rather from a policy perspective, also for politicians where maybe they have rather let's say, short-term, even just budget consideration. I don't want to say short-term goal, but just budget considerations into or taken into account. I mean, of course, I would say, especially with such a kind of, let's say, program, health should be seen as an investment, not as a cost driver, right? That's a totally different approach, of course. And the return on investment might just take a bit of time. That's the same as we see with other investments we do, let's say, in other areas of the system and or of the economics. But how could that potentially be implemented? I mean, is there a way that politicians might open that up and just say, yeah, I am now willing to, for example, invest short term, and maybe not myself, but somebody else in the future might get the kind of benefits also politically? Is there a way, any kind of discussion you can share from the Australia, or maybe even some other examples from other countries?
I mean, we have had presenting our results just recently at the European Parliament with regards to familial hypercholesterolemia and lipoprotein A. And what we've shown to politicians is that for every euro invested in screening children with FH, a Dutch government had a return of 8 euros over lifetime. So I think they speak with these metrics a bit better.
Yeah.
If you explain to them the return on investment or the inaction costs if they would not intervene early. And what I also found very interesting is that we were presenting the results from Mendelian randomization for 10,000 individuals that we have taken randomly from UK Biobank, but then I presented results at the population level. So what would be the savings in terms of outcomes, in terms of years of life saved, or in terms of how many heart attacks would be saved, those strokes, but also how many savings we will achieve by early preventing in terms of societal perspective. So we have not included only the impact on efficiency of healthcare, but we have included how is that going to impact society. So I feel they understand, but I guess when you think about other priorities and diseases, they always have to think about opportunity cost. And I feel that cardiovascular disease provides a very good opportunity cost because majority of the modifiable risk factors that play a role or interplay in cardiovascular disease are modifiable.
Yeah, I think it's a good point. I think cardiovascular, diabetes, and both are basically, let's say, firstly, interrelated. And secondly, I think they are big cost drivers for the systems as well. So they should be at least somewhere in the focus, right?
Yeah, and we have interventions available.
Yeah.
That we know they work and we know they are cheap.
Yeah, exactly. I think that's another point. I fully agree. So I just touched base very quickly on health as, let's say, investment. And I mean, a quite interesting other, let's say, area you're working on is, let's say, maybe call it productivity beyond cost, which has been, I think, not only just recently, but at least in the last couple of years, rather more being discussed in different systems, not only in the academic world, but also with politicians, health politicians and the like. Can you just put a bit more light on it? I mean, how, or let's say, what is the approach there, what you are going there beyond maybe what we have just now being discussed with complex disease models and the like? I think you're also going a bit into a slightly different direction on top.
Yes, additional value to providing with regards to decision making. We had a productivity commission around in September in Australia, and the only thing that we were all interested to talk about was productivity. Mm-hmm. But productivity as an output. So politicians are interested quite a lot about productivity. But my group has worked quite a lot in health productivity, so how productivity impacts health. And we've developed this new metric, which is called productivity adjusted life years, to look at the impact across diseases. So a productivity index is multiplied by years of life lived. So a productivity index of 0, it's not productive, and 1, it's a fully productive. So we've looked specifically in the last, since 2018, we've looked mostly around 40 or 42 diseases across the globe. And we've looked at not only primary prevention, but also secondary prevention to measure the inaction costs in terms of productivity. And the whole idea behind PALIs was to give decision makers a tool that they can think or relate more easily. Because if you would say to a politician, one PALI loss, it's equal to one GDP, they understand it quite well. So with any preparation that you try to do advocating process, you need to decide first, who are you going to talk to? And I think choosing productivity adjusted life years in some instances has proven to be very useful for them. And the way how we looked at only on how it is impact on full-time equivalent employed population. So that's why we can attach one GDP if one PALI is lost to an individual. And because this is getting quite interesting, and as you pointed out, there has been a large increase of studies published in productivity, and not just sort of productivity of work, but also education as well, multi-sectorial. So people are trying to look at the return on investment that health has a multi-sectorial impact, not just on healthcare. And I think this is what's missing from the conversations where we go and discuss with the decision-making, the impact that prevention can have multi-sectorially, not just in health. But at the moment, we are just measuring in health. As I said, this is getting pretty big, so we thought that, and we presented this work at a range of conferences, and one thing that always came was, what about unpaid work? Mm-hmm. How are you going to quantify that? So then we went and looked at some of available data sets that we have, which is called HILDA, household data that individuals give information about how many hours they work, how many hours they do of unpaid work, and what is their absenteeism. So we've used that data to generate population norms about productivity based on paid and unpaid work. What we are finding challenging is, how do you measure efficiency of unpaid work? Is it going to be only via presenteeism, or is it going to be via absenteeism? And the reason why we would like to include unpaid work as a part of the productivity adjusted life years is that in low and middle income countries, women, for example, are responsible for a large proportion of unpaid work. Yeah. And we would like that unpaid work, it's not that we are proposing anything new, it's something that it's been they're being quite people vocal to count unpaid work. But what is new is this idea framing and inclusion in HTA process as an outcome measure rather than as a cost. We have had some success in terms not implementing at the HTA process, but with some big national health grants. For example, we've used a PALI as a return on investment tool to talk to decision makers. Medical Research Future Funds, one example I can give you, it's Australian Epilepsy Project. It's a multimodal registry which collects data on MRI, on genomics, and a lot of patients' reported outcomes. And when we submitted application, we have included PALI as a metric measure to be funded. And we found that politicians and also decision makers who would interview you would relate to that PALI loss much more nicer than QALY loss. Yeah. We don't anticipate to change quality. We would like this to be used as an additional value of information. And I know that this is something that can be used to assess a opportunity cost of different diseases, how productivity impacts. So if you, let's say, have 1 billion and have a chance to assess all diseases and look at the impact on productivity burden, this would be a good way to actually structure productivity adjusted yield loss due to certain condition, and what is the cost of inaction if government is not intervening early enough. So that's been very, very interesting. And that's why we are now looking at not only paid work, but also unpaid work, because in the HTA process, they need to have both in place to be able to make decisions.
Yeah, no, that makes a lot of sense. That makes a lot of sense. I mean, just a quick one also on this one. I mean, I totally like that idea with paid, unpaid work and all of the kind of things. I mean, what or how do you, for example, include as well, let's say, kids? I mean, toddlers, school kids, because of course, you can always, or I could just imagine you could as well just take, for example, education might have an impact, as we all know, on further productivity in the future. Are you taking that in that way into account? Of course, wherever health has an impact, we could have different kind of, let's say, areas where, for example, some diseases are just, let's say, starting with young ages or whatever. I mean, whenever you are, let's say, interfering a bit early, you might have those additional productivity boosts maybe as well later on. Is that as well something you're taking into consideration, I presume?
That's a great question, Stefan. I think this is something that it's not previously considered. We have done a systematic review of evidence, how productivity, health productivity and education is measured. We looked at different questionnaires that have been used. And as you pointed out, certain conditions develop in early age. So obviously you would like to point that out and identify how different conditions impact early childhood and development, and how that's going to impact on their education and development, and also then retaining future work. So this is something that we are looking as well, but that's a separate issue, because we have to look at it in a different way in comparison to how we're looking paid and unpaid work.
Yeah, no, perfect. Very good. So moving a bit towards the end, you have also worked in Switzerland and also with the Swiss decision maker, BAG. I mean, if you compare Australia, maybe with Switzerland, but maybe also with some other systems, you just mentioned that you have also been working or presenting at different, let's say, policymakers across the world. How, let's say, open do you see, for example, those systems for such kind of broader or new measures? You mentioned some of those already during the last 30 minutes, but how open are they really? Especially when we would be thinking about those productivity measures, health as investment, and or equity, which I think to me is interrelated anyway.
I believe when I left Switzerland, the HTA process with regards to cost effectiveness was nice to have. Mm-hmm. I'm sure now has changed and it's more formalized because it's been 7 years. In Australia, we potentially submission can do a societal perspective, but it is not clear how that will impact the base case incremental cost effectiveness ratio. Is that the information that we'll use for decision making, or they will use it from a healthcare perspective? I think there is a broad range of discussions at the moment, what should be included or what should be not. But as pointed out, there are so many challenges to train and recruit the workforce to do that information, and HTAs will create more work for themselves. And this has been very challenging. And I know a lot of European countries and, for example, Australia, Canada, and UK were trying to harmonize their HTA processes And I know that UNETA has tried to harmonize their processes as well. So every additional thing is going to be taking a long time to be implemented in the decision-making process. But my time in Switzerland was very interesting because it was split between building global models for industry, for new technologies to be implemented, but also local ones to the BAG. But I have a half time of my part of my work was dedicated to working with Swiss Medical Board, which ceased in 2022. But I had opportunity to assess a number of technologies as being part of assessment team, where we have looked not only the new technologies, but we have looked at existing technologies for continuation or for disinvestment. And that I found very, very interesting because this is something that not many countries do, the disinvestment part. And by doing disinvestment, you obviously would save a lot of money to the healthcare system, but also to patients out of pocket. So this is one way which I think countries can learn from Switzerland because it was a very open, transparent process where clinicians will give questions that they would like to be addressed at the canton or at a bigger level in Switzerland. And then we will evaluate those questions. And then the scoping review would happen. PICO questions would be defined, so population intervention, comparator, and outcome. And then you would have a assessment team, and then you would have a appraisal team and the decision process. And what I found very interesting as well was that not only the clinical part and cost effectiveness part and budget impact that was included, but legal and ethical part played a similar role or part in the decision-making when those technologies were looked at from a Swiss Medical Board. But now mostly technologies now are looked from a federal office of public health in Switzerland. And they have a very organized processes where they look at clinical cost effectiveness, budget impact. I don't know how much of add value they look, but I'm sure if industry would submit something such as societal perspective, they would definitely look. Equity might be a bit challenging because to be able to include distributional cost effectiveness analysis into a submission process, you have to have distributional health values by socioeconomic status. And not many countries have published those values. I'm aware of several. For example, Norway, UK, US, Australia have some of those norms published. And if they are not published, you can't undertake the study. So I'm sure this is something that will come in the future, but we also have to be careful about limitations of these methods and as well enormous amount of resources that HTA processes would need to put these things in place.
Perfect. Very good. I think, Zanfania, that was really great insights. I learned again a lot. Thanks for the great discussion. Looking forward as well to hear how those kind of things might move as well further in Australia, but also, and of course, beyond that, maybe in some other parts of the world. Thanks a lot for your time, and hopefully maybe have you again back on the show somewhere in the future.
Stefan, it's been a pleasure to spend time with you.
Insights from Australia, but probably also beyond, especially as we have now just discussed with Zanfina on or the Australian healthcare system, which looks, let's say, quite similar a bit, at least what she was telling, with different institutions like similar systems in the UK and Canada. However, I think what was really interesting was as well the discussions on health productivity, on equity, and how that could also be implemented into the different process. I think it's quite clear that, let's say, the distributional cost effectiveness, for example, could be a good pathway in order to have quantitatively as well equity included in the assessment. She said as well, however, as well, keeping in mind the whole kind of internal processes within HTA and payer institutions, which would also mean that you would also need to have the experts being able to analyze and interpret / recommend, of course, the outcomes of those. Very similar, let's say, linked to that as well. Distributional cost effectiveness would also potentially need to have complex disease models, and within those, the group around her were also able to, for example, already calculate cost savings of preventions in the cardiovascular area. Complex disease models, again, need a lot of, let's say, further methodologically driven kind of decision making, which data can be extrapolated in which ways and also for how long. But I think the really interesting one as well from my perspective was then the further link, and I think everything is interrelated to each other. What we discussed this today was also on the productivity adjusted life years, where not only the economic perspective, but also the paid and the unpaid work, for example, by caregivers who are taking care of ill patients is or can as well be included. There are quite nice papers already published out there, especially by her and her group. However, there were still open discussions, as she was as well alluding towards, how, for example, to include elderly or as well toddlers and school kids with different kind of methodological kind of questions. Anyhow, overall, I think there are potential new measures to also be included to have a broader view, taking health as an investment and even further strengthen equity. Key problem for the current perspective, probably especially being implemented from a political perspective in different systems, is, I think, at the end of the day, as well, the workforce within those institutions. That was an episode of MAP, the Market Access podcast, provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. MAP is available every second week with a new episode, so watch out. And in case you might have questions, contact me directly and or visit our website on www.marketaccess-pricingstrategy.de.